It is a huge honor today for me to be podcast interviewing Rick Schwartz. He goes by Rick unless he's in trouble by his mom, then he goes by Richard. And he's in San Antonio, and he is a legend in endodontics. I'm so honored to have you today. You really are amazing. Dr. Rick Schwartz was a restorative dentist for 19 years prior to entering postgraduate training in endodontics. He attended a 2-year general dentistry residency and then did a combination of private practice, teaching, and dental materials research before entering endodontic training in 1996. He has authored over 100 articles and abstracts and was a cover author on 3 editions of Fundamentals of Operative Dentistry by Quintessence Publishing. He is first author of the book Best Practices in Endodontics, a Desk Reference, recently published by Quintessence, and is a cover author on a CBCT Primer for Endodontics, soon to be published. He has lectured to a wide variety of audience on topics related to endodontics in the U.S. and 14 other countries. For the past 17 years, he has been in full-time private practice, limited to endodontics in San Antonio. Rick, seriously, dude, this is an honor to have you today. How are you doing?
Oh, I'm doing great, thanks.
So I want to ask you the most off-the-wall question. Why do you think, of all the general dentists I know, half of them hate molar endo? And then the other half, when we look at the online CE courses on Dental Town, endo is always every single month it's first or second in online CE views. It's just a really difficult procedure, isn't it?
Well, I mean, sometimes it is. I think that a lot of general dentists, what happens is they get into, they come out of school and they attempt some of the difficult cases and things don't go well, and some of them continue to do it, but a lot of them kind of back off. And you know, the simple, straightforward cases, probably a general dentist can do them just as well as an endodontist. But the complicated cases, you know, it's harmful to your practice if you get bad outcomes. And after a while, most dentists come to the conclusion that it's better for their practices if they don't do everything themselves.
Well, it's simple. You know, my jealousy towards you is when I look at my friends that from dental school that went into specialty, their whole life they get a focus on one area. And then as a general dentist, I mean, we have to keep up on root canals, fillings, crowns, bonding, veneers. I mean, it's you just can't do it all.
Yeah, it's impossible, really.
I mean, look at implants. Just the bone grafting alone would be a full-time job in continuing education and spinning blood and platelets. I mean, gosh, where does it end?
You know, it's a funny thing, but when I started as an endodontist, I'd been a general dentist for a long time, and my plan was that I was going to focus down on a few procedures and hopefully become very good at those. But what's happened over the years is actually I'm doing more and more stuff again. I wasn't planning to do any restorative after I graduated my residency. My plan was that I was going to put cotton and cavit in all of the teeth and not have to deal with that. Well, we started seeing problems coming back after a while, and we decided that it was important that we start doing the foundational restorative. So basically, my partners and I restore all of the teeth now, the initial restorative on all of the teeth that we do endo, just for a variety of reasons, but mainly because it's the best thing for the patients in the long run. And the other thing is, I mean, I'm doing some extractions now, depending on the situation, just because most of my referring doctors, they just want things taken care of. They don't care so much who does them. They just want things taken care of so they don't have to deal with them, so that they're what's most convenient for their patients. I used to do a lot of IV sedation in my general practice. I wasn't planning to do that particularly, but we've gotten back into that. I do crown prep sometimes for some of my restorative dentists. It's funny how I don't personally do implants, but some of the endodontists I know have gotten into implants. It's funny how it's expanded out into not at all what I expected.
Let's talk about the buildup, because a lot of people say that when a root canal fails, it's from coronal leakage down. It's not from leaving infection in the tooth. Do you think leakage from the final restoration, what percent of root canals do you think fail from restoration leakage?
Well, actually, I can tell you fairly authoritatively on that topic. Just in general, First of all, nothing good happens if you don't restore the tooth right away. Only bad things happen. The tooth breaks, you get contamination, it doesn't get restored, and they get caries. We actually did a little study in our practice about 5 years ago. We recalled 100 patients who we'd done endo on at least 10 years earlier, and which is a big job, let me tell you. We had to call about 250 patients to get 100 to come in. Anyway, and so then the ones that had failed, we tried to get a hold of the old charts from the restorative dentist and see how they failed, because endodontists rarely get to see their own failures. You know, we're fat and happy. We sit in our office and we think, well, we did our job and everything is great. When a tooth gets extracted, we don't usually hear about it unless we happen to see the patient later on for another tooth. So anyway, out of those 100 teeth that had been extracted, or 100 patients that had been treated, 20 of the teeth had been extracted, which, like, I was ready to kill myself. I couldn't believe how many failures that I'd had. And what we found was only 4 of them we could really say were endo failures. The other 16 were either the tooth had cracked or the crown had snapped off or they developed caries and had been extracted. So the vast majority of the teeth that fail, it's because of structural integrity of the tooth or because of restorative issues. So that's part of it. And there was an article that came out about a year ago, a little less than a year ago, from Scandinavia. The primary author was a guy named Kvist, Kvist, and they found exactly the same thing. Almost all of the failures were due to were structural failures of the teeth. They had a little bit more caries than we did, but they had hardly any endo failures either. And this was in a public health clinic. Anyway, so the bottom line is that you need to start out, first of all, with teeth that are structurally strong, and then second of all, they need to be restored well. And the best way to do it is to restore them right away after the endo is complete. The tooth's isolated, there's no opportunity for contamination. And now, of course, not all endodontists are well versed in restorative, but the ideal situation is complete the endo, have the endodontist restore it if they know what they're doing, and then have the restorative dentist, take it from there. The thing is that contamination, there's just nothing good happens if the restoration is delayed.
Well, Rick, we've seen in dentistry where in 1950, average overhead was about 40%, and now in 2015, it's nearly 64%. And these bonding agents are $1,250,000 for a barrel of bonding agent. When you're down there in Texas, where today I think crude oil opened up at $35 a barrel. What about the old-fashioned just $1 capsule of amalgam? Is amalgam because the reason overhead's going up is because insurance companies have pretty much held the price, and every time the earth goes around the sun, inflation goes up. So we've really eroded our margins about 25%. Is an amalgam a low-cost alternative build-up after a root canal in a molar, or would you just want to only do adhesive dentistry?
We like amalgam. We would like to do amalgam a lot more than we do, actually. The problem is that some patients don't like it and some of our restorative dentists don't like it. So we use it, probably 25% of the time, something like that. Amalgam is strong. The seal improves with time as opposed to composite where the seal breaks down with time. If it's not in an aesthetic area, that's oftentimes our first choice, is to use amalgam.
Why is that so controversial among dentists? Dentists say things. I want you to address this. I could split the dentists in America in half. Half of them say amalgams are horrible because they fracture teeth, and that, when you place the MOD amalgam, it's doomed to fracture and fail. But I see the research showing that these things can last, 35 to 40 years. Then other people say, well, endodontists love posterior composites because they irritate the pulp and they cause a lot of endo. And then I look at a lot of research that says these posterior composites are only lasting 6 to 7 years. What do you think is, forget looks and aesthetics and all that, because you're talking to a short, fat, bald guy. and you don't see any of my teeth. What do you think would last longer in an MOD amalgam? I mean, an MOD restoration on a first molar.
Well, let me just say, first of all, that amalgam is much less technique sensitive. It's easier to use successfully. Composites, when they're placed really well, do pretty well, but oftentimes there's not good isolation. If you get contamination, you get very poor bonding, and that makes it more susceptible to leakage and breakdown later on. I mean, here's another little study that we did in our practice a few years ago. We looked at 100 patients who'd had composite buildups that were at least 5 years old, according to the patients, that had crowns on them. And one of the things we do when we make access is we paint the inside of the preparation with caries detectors. So we did this on 100 consecutive patients with 5-year-old composite buildups. Let me ask you, what percentage of them do you think had caries underneath?
I would say 80%.
Well, 37% had frank caries, where it's stained along the margins. When you poke at it with an Explorer, it was soft. And another 22 of them had staining, but we couldn't detect any softness. So a lot of these things are leaking. Now, some of those probably, they didn't remove all the decay originally, so it's not all because of leakage, but a lot of these things have leakage underneath. So my feeling about composites is that done well, it's about a 15-year restoration. An MOD, to answer your question, an MOD posterior is probably about a 15-year restoration if it's done well.
Amalgam or composite?
Composite, I'm sorry, did I say amalgam? Yeah,
so you're saying posterior composite done well is about 15 years?
That's my feeling anyway, you know, all things being equal. And I can tell you, I have a friend of my wife that I follow that had some conservative MOD amalgams placed in 1958. So what does that make them? 57 years old now. I can promise you that you're never going to see a 57-year-old composite.
Absolutely not. So you're saying probably the average posterior composite done well, maybe 15 years?
That's my opinion. I mean, I don't.
Right.
The research says.
What would that be if it was amalgam? What do you think? 100 MOD amalgams done well.
I think that from what I've seen anyway, this is not research based, it's just my opinion, but I mean, I see lots of old amalgams that are 20 and 30 years old that are doing just fine. You know, they're staying, you know, they're discolored and maybe the margins are dished a little bit, but they're doing fine. So I'm an amalgam fan, but like I say, a lot of my referring doctors are not, and I'm kind of obligated to do what the referring doctors request. And of course, when I place access restorations or place buildups, they're done well, they're isolated well, and they're done following the instructions by the manufacturer. Most of them, many of them are underneath crowns. So I think those, you know, when they're protected by a crown, I think they last more than 15 years. The other thing with composite is if you've got enamel margins all the way around, those have good longevity. The problem with an MOD is that you don't have little if any amalgam at the gingival margin, and that's where the problem is.
So, you know, if you do what percent of the dentists in San Antonio that you work with accept insurance, would you say?
Well, most of them accept some insurance.
So if the insurance is setting the market price, and the market price is, is not been going up, then you have to lower your costs. And if there's going to be a crown over that tooth anyway, I mean, I just don't understand why you just wouldn't go to amalgam. And when these doctors, the same doctors that say, well, I'm amalgam free, the next question is, why is my overhead so high? How can I lower my overhead? And I'm like, dude, you're paying over $1 million a barrel in bonding agent. And I could go on and on that forever. Show me the book to the left there. Is that your bedtime reading?
Yeah. So this is a book. Can you see it?
Yeah, Best Practices in Endodontics, a desk reference. Tell us about that journey.
All right. So we have this online discussion group of endodontists from around the world. And we discuss all these things. We discuss literature, we post cases, we sometimes we'll
Is this
have
the TDO community?
TDO. It's a software users group.
And that's who's that guy out of California? TDO,
Gary Carr from San Antonio. He has it's his company.
and it's endodontist only.
There's a few general dentists on there, but it's mostly endodontists. Yeah.
How many endodontists would you say are on there?
Oh, maybe 500, something like that. So we, over the years, we've discussed all these interesting cases and how to handle different situations and that sort of thing. And so we got the idea a few years ago, why don't we put these things down in writing and do a book? And so I have a relationship with Quintessence from my restorative days. And so I approached them about it, and they were interested in doing it. And so this book has, I don't know, about 40 chapters or so. And some of the chapters, the initial ones, are more geared towards endodontists. They're like how to set up your operatory properly, to utilize a microscope, how to do things ergonomically with the microscope, how to train an assistant to work under the microscope, how to document your cases, how to set up to do photography through the microscope and video, and how to document your cases. Those are things that primarily are of interest to endodontists. But the rest of the book is about mostly how to do a single procedure. Let me just flip through here. I'll tell you what some of the chapters are on. Oh, also there's a couple chapters on cone beam CT and endodontics. But then, for example, there's chapters on access preparations, how to obtain working length, how to prepare the canals, how to deal with calcified teeth, severe curves, a couple different methods for obturation, managing C-shape configuration. There's a couple chapters on retreatment. There's actually 6 chapters on restorative, evaluating restorability, pre-endo buildup, customized resin matrices, just things related to. There's a chapter on bonding to ceramic materials, because there's several different ceramic materials now, and you have to be able to identify them and know the proper bonding procedures for them. There's several chapters on how to deal with resorption. There's several chapters on trauma management. And then a few other things, horizontal fractures, how do you deal with those, perforations. Let's see, how to do just quality intraoral radiographs, how to take quality PAs for doctors, how to effectively communicate with patients, and just a few other things. Anyway, the idea is that if you haven't done a procedure before, or maybe if you have and you want to kind of bone up on it, you can just look at one of these short chapters. It tells you a little bit of background, what sort of armamentarium that you need, how to actually do the procedure step by step, that sort of thing. And many of the people that contributed to this, there's about 30 different people that contributed to this from 5 different countries. Many of these people are some of the best endodontists in the world, some of the best and most skilled endodontists in the world, and many of them are people you've never heard of, actually. Probably most of them are people that you've never heard of. Anyway, so that's kind of...
Well, I know you're a busy man, but Dental Town magazine goes to 125,000 general dentists every month in a 100-page magazine. If you ever have time to write an article summary of your book, that I would love to print it if you give away some.
I'd be glad to. Yeah, I'd be glad to.
And where can our listeners order that book? Quintessence Publishing, do you know the website address?
You know, if you just go to Amazon, that's probably the easiest, and they sell it at a little bit of a discount. If you just type in best practices in endodontics, it'll take you to the proper page.
Best practices in endodontics, and then also a desk reference. Is that part of the title too?
Desk reference, yeah, that's
best practices in endodontics, a desk reference by. Would it be Rick or Richard?
Richard.
Richard.
Yeah, Richard,
So your mom's yelling at you from that book that you're in trouble. You must have left a chapter out if you put Richard Schwartz on there. You left it. There's got to be a typo in there since you didn't go with Rick. I want to ask some questions that I always see on the endodontic threads on Dental Town.
Sure.
The website's got a. Oh, by the way, what's the website address of that TDO website for endodontists only?
It's www.tdo4, the number 4endo.com.
TDO4 Endo. TDO4 Endo. And will Gary let just a general dentist join, or is that just by invitation only for a general dentist?
Well, you have to either use his software, or he also has some image management software, which is a lot less expensive, which you can buy, and then you're allowed onto the website.
Huh? And is he still doing endo?
Oh yeah,
Gary?
3 days a week. Yeah.
3 days a week. He's still doing endo in near San Diego.
Yeah, in San Diego. Yeah, he's a pretty remarkable guy, actually.
Does he still collect horses?
I don't think so, or I haven't heard about that anyway.
I remember back in the day he was into horses. Hey, I want to ask you some questions that I see. I was looking on the endo forum today on Dental Town. What do you how should a dentist be thinking when the apex locator measurement doesn't really look like the radiographic image? Who are you to trust when those two don't look like they agree?
So when you look at working length, there's like 4 methods for getting working length. Some people can say they can do it by feel, so that's the worst method to use.
Is that the Stevie Wonder method?
Yeah, sort of. Yeah, some people claim they can do it by feel. The next most accurate is radiographs. They're kind of misleading a lot of times because the apical foramen's not necessarily at the apex, and plus sometimes it's just hard to see. The apex locator is the next most accurate, and it's pretty good. It's pretty accurate most of the time. But actually, the most accurate method, and there's a chapter in the book about this, is to use paper points. And most people actually use paper points the wrong way. The best way to use them is, first of all, you get an initial idea either from your radiographs or from your apex locator as to the proper length. And then you prepare the canal to that length and dry it, and then go in with a paper point and see where you get, a wet spot at the tip. And do that a couple times and see what sort of length you get. That's actually going to be a little bit short because of wicking that you get in the paper point from the moisture. So then go back with paper points a little bit shorter than that, let's say 0.5 millimeter shorter. And if the tip is dry, then go a little bit farther. And if the tip is still dry, then go a little bit farther. You want to use the longest length where you can get a dry paper point. And that's going to be very accurate. You're going to be right on every time if you do it that way. Now, you can't have weeping into the canal. You have to have a dry canal, obviously. But if you prepare the canal, if you get patency, you prepare the canal, and then you're able to dry it with a fairly consistent wet-dry line, then just back off and use the longest length you can get with the paper point. And like I say, you'll be right on every time. The times when an apex locator doesn't work that well are like if you have apical resorption, or if you can't get the canal dry. But this paper point method actually is the best method to use in all different situations.
So now you have your paper point dry, you have your length, you really feel your length. Then what would you do next? What sealer would you use, and how would you apply that? Would you apply that with a paper point, or do you like to use the lentillula and spin it down into the canal?
Okay, so first of all, I do almost no single visit. I know probably most endodontists and most of your listeners or your readers probably do it mostly in single visit. I do it almost no single visit treatment, and the reason for that isn't that necessarily it's more successful doing that way. At least the literature is not very clear on that. The reason I do it is that the doctors that I refer to, the biggest thing I have to offer them is success. Okay, and there's a certain percentage of cases that endo just doesn't work. If you look at the literature, about 5 to 10%, there's persistent problems with them. Well, I can't be sending cases back to my referring doctors with problems. And the only way that I can tell for sure if I've eliminated their problems is to start treatment, put calcium hydroxide in, see how it goes, see if the symptoms go away, if the sinus tract heals, if swelling goes away, if deep pockets reduce. I don't finish the cases until all of those things have been resolved, which is usually at the second appointment about a month later. So then I finish the treatment, send the patients back to the referring doctors. In San Antonio, most of the best restorative doctors refer to me or my partners. And the reason is because they don't get cases back with problems. We don't ever get phone calls from them saying, hey, the patient's in here, I'm getting ready to do the crown prep, and they say the tooth's still symptomatic. We've eliminated all of that by this multi-appointment process. So that's the first way that I would answer your question. So then usually we put calcium hydroxide in. But then when it comes time to obturate, I recheck my working lengths to make sure that they're still good. And then I just dip some sealer on the tip of my cone and seat my cone and then go through with the obturation process. I do a warm vertical technique, but honestly, the sealer that you use is probably like the least important aspect of endodontics. And the obturating technique that you use probably doesn't make any difference as far as success and failure go. So people always ask me when I lecture, what sealer do you use? I use AH Plus from Dentsply. But honestly, and the reason I use that is that since I'm going to go ahead and do the restorative, I don't want to have to deal with eugenol and with bonding issues, and plus it cleans up nicer than the eugenol-based sealers. But honestly, the sealer you use just doesn't matter.
What about the calcium hydroxide? Does the brand or potency or any of that matter?
I don't think so. I mean, I don't know for sure. I use UltraCal by Ultradent just because it's very simple to use. You can inject it in there and then spin it a little bit with a lensulo to get it down to the apex. But honestly, I don't think it matters.
So back to that sealer, what do you think of some of these general dentists that are using a gutta-percha carrier, like a thermophil, a plastic carrier gutta-percha device? Does that make it harder for you to retreat should 5 to 10% fail? Are you a fan of these, or do you wish your referring dentist stop using them? Or
so I don't have a problem with thermophil at all. I think it's as long as you do everything else right. Here's the thing about endo. As long as you locate all the canals, you clean them reasonably well, you're going to have a lot of success with endo. So I think thermophil is fine. I don't have a problem with it. A lot of the restorative dentists use thermophil in San Antonio, and so we have a lot of experience retreating them. And I wouldn't say never, but I rarely have a problem getting them out. I have no problem at all with thermophil. I think it's as good as any other method of obturating, and usually they look better, at least radiographically, the ones that have been treated with thermophil than the ones that have been obturated with thermophil versus other methods that we see. The other thing I like about thermophil is that if the obturating material is sticking out the end of the root, if it's got a percha, you have no chance of getting it back in, very little chance, let's say. With thermophil, you just snag the carrier and pull it out, and you can pull everything back in. So whether that makes a difference in success or failure, I don't know, but I know my retreatments look nicer if I can get everything out.
I am so old. I can remember flying to Ben Johnson's office in Tulsa, Oklahoma, watching him make these by hand. He would get gutta-percha out of his operatory drawer and a flame and a file, and I watch him roll these things, like kind of like watching your old uncle roll a cigarette, and he would just roll a thermophil. He was just a wild man. He was so interesting and smart and fun. So back to Ben Johnson's company, Tulsa Dental Product. When you're saying these teeth, 100 teeth, 20 got extracted, do you think those rotary files, do you think the 0.04 or 0.06, do you think we're removing too much structure in the root and this is contributing to final failures? Do you think that our tapers are too big? I mean, back in the day, we used to use Gates Gliddens, and what was the other one besides the
Piezos.
The Piezos, and man, you just take out Frosty the Snowman tooth structure. I mean, there'd be like you're cutting a board.
I most definitely think that we should be as conservative as possible on our access preparations, as conservative in our shaping. There's an idea within there's a lot of resistance to this actually in the endo community, and the idea is that if you don't prepare, if you don't make a big access opening, you're going to miss things, or you're going to have more problem with broken instruments and that sort of thing, procedural accidents. And then if you don't prepare the canals to a big size, that you're not going to have as much success with endo. There's really not anything in the literature that says that. There's really no outcome studies that have compared small preparations to big preparations as far as success and failure of the endo. What we found in our 10-year recall thing was that we didn't see very many failures at 2 years or 3 years, hardly any. Most of the failures we saw were like in the 7, 8, 9-year time frame. The most common failure we saw actually were premolars snapping off. And so it changed the way we practice in a couple of ways. One is that we're trying to do everything much more conservatively now, preserve as much tooth structure as possible. And another thing is that premolars and anteriors, we put fiber posts in them now, virtually all of them, which is getting off on a little bit of a tangent. But there's an idea, again, in the endo community especially, well, in the dental community in general, that posts don't make teeth stronger. And that's based on two studies, one that was done in the 80s and one that was done in the 90s. If you look at the restorative literature for the last 10 or 12 years, there's overwhelming evidence that fiber posts make teeth stronger. There's at least 16 studies that show that. There's hardly anything in the dental literature where the evidence is so strong, and yet nobody in the endo community pretty much has read that literature, and not very many people in the restorative community either. So, and it just makes sense. I mean, a fiber post is something that has more or less the same properties as dentin. So instead of putting gutta percha in, you're like putting another piece of dentin in there. It just makes common sense that it would make them stronger, and the literature is overwhelming in supporting that. So here's the key to longevity in endo. Start out with teeth that are substantial and are strong, not teeth that are just gutted with decay or where there's no coronal tooth structure left. Be as conservative as possible in your access preparation. Be as conservative as possible in your canal preparation, and then restore the teeth immediately with sound restorations. And of course, do everything right restoratively, crowns that fit well, proper occlusion, that sort of thing. Those are the keys to longevity in endodontically treated teeth. And it's funny, there's a lot of resistance to this idea of doing things more conservatively in the endo community, but I lecture a lot to restorative groups, to prosthodontic groups, what I call sophisticated restorative dentists, like implant study clubs and Seattle study clubs and that sort of thing. And they're all over this idea of conserving tooth structure because they have to see the teeth that fail. So if they have a tooth that has endo done and the tooth breaks in 5 or 7 or 8 years, the endodontist doesn't suffer for that. The endodontist already has put the money in the bank and spent it. The ones that suffer are the patients and the restorative dentist. The restorative dentist has to deal with an unhappy patient. So those are the keys, anyway, to longevity in endodontics. It's not so much how the endo is done. It's really the structural integrity of the tooth and how the restorative is done.
I would so love to get one of your courses on Dentaltown. We have 205,000 members. We put up 350 one-hour minimum length course. They're 1 to 2 hours. They've been viewed over 500,000 times. If you put up that course, you'd be teaching dentists in India, Asia, Brazil, around the world. Any chance you think we could ever get a course from you?
Sure, I'd be glad to. Yeah, there's probably about 4 or 5 things I do that would work well with your program.
Well, I think that it sounds like the most important course would be a fiber post or include talking about a fiber post billet, because I mean, there's a lot of general dentists who believe the only thing a metal post does is fracture a tooth, or you're removing too much tooth structure. It sounds like the fiber post. What brand of fiber post does that matter in these 16 studies?
90% of them are made by what's the French company?
Septodont?
No, I'm blanking.
That's the anesthesia.
Yeah,
Myler? Mylar for? Or
I can't think of it right now. Anyway, they're made by 90% of them are made by the same company in France, and so
is that the one that Dentsply bought?
no, they're an independent company. God, I'm sorry, I'm blanking on the name right now. It seems to happen to me more and more these days.
I have four boys, and I feel sorry for them because every time one comes to my house, I always call them the wrong name. Is it Micromega?
No,
Not Micromega?
it'll probably come to me after a little while, and I'll tell you what it is. But anyway, so they make them for almost all it. They make them for Bisco. They make them for 3M. They make them for almost all the companies. Um, Here's the key with any kind of post, whether it's metal or fiber, is that prepare the canal, do the endo, prepare the canal as conservatively as possible, and then don't remove any more dentin to put the post in. Okay, don't take out a twist drill and make it bigger. You need to pick a post that fits the canal that you've already prepared. Don't make the canal fit the post. And that's the key to...
Is it RTT Dental? RTD Dental?
yeah, that's it. Yeah,
That's it.
that's
RTD Dental, yeah.
Yeah.
So they're making a lot of these posts for other companies. They're an original manufacturer.
Yeah, they make almost all of them that are sold around the world.
Okay, I'm sorry to interrupt you on that, but what were you saying about? Continue on about those these fiber posts.
Yeah, so do the endo, fit a post to the existing canal, and if you do that, you're strengthening the tooth. The evidence is just overwhelming. Now, as far as with metal posts, it's about 50-50 now. There's a couple of studies that have come out that show that metal posts make the tooth stronger. The advantage, at least the theoretical advantage of the fiber posts, is that they distribute the forces better. And so you don't get concentration of forces like you do with the metal post. You get a concentration at the end of the post. The worst thing you can do with the metal post, so forces concentrate in a root two places. If there's nothing in there, they concentrate at the crest of the alveolar ridge. If there's a metal post in there, they concentrate at the end of the post. The worst thing you can do is put a metal post in where the end of the post is right at the crest of the alveolar ridge, because then you're just setting yourself up for failure. One of the problems with metal posts is that they're parallel, and so you have to actually, almost all of them are parallel. And so what I do when I use metal posts is that I take a diamond burr to it and I make it tapered so that I can fit it into the existing canal. One other thing with metal posts is we're making these canal preparations more and more conservative. Fiber posts are not as strong as metal posts, and so for some of the really conservative ones, like on lower anterior teeth, for example, I'll use a metal post instead of a fiber post.
And how do you cement these? Are you using the kit from the fiber post company, or is it?
Actually, the way I cement them is that I like to have my posts cemented with the same material that I use for my buildup. I like to do it all in one step. So the way I cement the posts is I use a dual cure bonding agent first, etch and rinse and apply the primer and adhesive. It's dual cure because the light's not going to penetrate all the way deep into the canal, obviously. And then I'll use a dual cure buildup material. The particular one I use is Luxacor, which is made by DMG, a German company. But any dual cure buildup material will work. So I inject that into the post space, I seat the post, and then I do my buildup and light cure everything.
Do you see much? You're talking about Luxacor from Germany. Do you see much variance of how endo is done between North America and Europe and Japan, or is it pretty consistent around the world, or is there I'm talking among people who do this all the time, like endodontists?
Yeah, I'd say it's very consistent. I mean, I think there was a time when America had pretty much of a monopoly on the best clinicians and the best endodontists, and that certainly is not true anymore. There are just some amazing clinicians in other countries that are, the top people in all the countries are just outstanding.
And speaking of the most controversial endodontist of all time, Angelo Sargenti from Italy, how would you remember him by? I mean,
Well,
how would you sum up his career?
He was hated in the endo community, but I don't know that we have strong evidence that there was a, he was in favor of very conservative preparations of the canals. And here's what I would say is that, again, if you locate all the canals and you prepare them well, it probably doesn't matter very much how you obturate them, and probably Sargenti would be fine. The knock against Sargenti was it contained formaldehyde, and if you got it down in the mandibular canal, it would cause damage, it would cause numbness. Honestly, the same things are true if you get eugenol down in there. If you get calcium hydroxide down in the mandibular canal, you're going to cause damage to the nerve and numbness. So I don't have that much of a problem with Sargenti.
So what would you say to you're talking to several thousand general dentists, and when they go to a dental convention, there are so many different rotary endo files for sale. Do you have any recommendations? How should a general dentist look at all these? And it seems like the taper would be a big factor. I mean, an O2 versus an O4, O6. What advice could you help a general dentist in looking for an endo file?
So first of all, pretty much all of the files that are on the market are fine. Okay, they've all been tested and they've all kind of followed they all can be used successfully. I'm inclined again to use the less tapered ones that remove less dentin. Doing things more conservatively makes the procedure more difficult and more fraught with danger. It requires more skill and it requires more time. And so those are all negative to some extent. But as far as what's best for the patient, what's going to last the longest, I would use the less tapered instruments. And I've kind of gone through a process. I initially did everything with those 6 tapers back when we did our recall back in 2000 and earlier was when I was treating those patients. Pretty much everything was 06. Then I went to 04, and I've actually gone now to some files. The primary files I use are called V-tapers. They're relatively new. They're made by SS White. They're very conservative. They have taper at the apex, but then very little taper the rest of the way. And so you're removing relatively little dentin. Just in general, I guess the one recommendation I would give is to whatever system that you use the heat-treated ones, the ones that they're coated and they're heat-treated. They're very flexible, and my experience with the V-tapers is that they're almost impossible to break. So far, I've only used them probably about 6 months or so, so it's too soon to say. But so far, I haven't broken a single one, and I unfortunately have somewhat of a propensity to break files. So I would use the heat-treated ones, and all the different companies make them now.
And do you single use your files, or do you ever autoclave them and reuse them?
Generally speaking, I single use them, but I occasionally, if the file's not stressed very much when I use it the first time, and there's no unwinding or anything like that, then I'll use it a second time.
And is that do you think that increases the fracture if you use it a second time, or is that only?
If you use them routinely more than once, it probably increases the fracture. It's more the clinician. The old saying, it's the Indian, not the arrow. All of these things, it's more the clinician than it is.
I've never heard that. It's the Indian, not the arrow. I love that. I'm in Arizona where 25% of the state is Indian reservation. So I'll tell my Indian dentist friends that.
Almost all the things in dentistry, it's not so much the materials you use, it's not so much the instrument, it's much more, the clinician is much more important factor.
In fact, I just had dinner last month with the first Native American Indian dentist in the United States, with him and Jack Dillenberg. So, is the next '06 was too big? You were with '04. You've gone smaller. Would the next logical file be a .03? I mean, is that where the market's headed?
I think this variable taper actually is the best because you'd like a little more taper in the apex. You'd like the apex to be a little bit bigger, and you'd like to have kind of a capture zone down in the apex to help especially with these really thin preparations to help avoid overfills. Yeah, so I think variable taper is where we're going to be probably going forward. Yeah. And I think the V tapers, I can't remember. I think they are something like O2 or O3 taper once you get away from the apex.
So let's jump to your other book where you're a cover author on a CBCT primer for endodontics. Has CBCT was that a game changer in endodontics?
Yep, about every 10 years or so, another game changer comes along, and that's the most recent one. Yeah. I would hate to practice without it. It just provides so much information ahead of time before you pick up a handpiece or start giving people injections. You just have so much more information about the problems that you might run into, first of all, and also sometimes you see things that you decide not to do treatment. You decide it's better to extract the tooth and do a bridge or an implant.
And what percent of the teeth that you endo do you get a CBCT before you treat it?
You know, it's getting to be more and more. Honestly, I'd like to do it on every patient, but it's just not possible to do that. Simply, or at least in my practice, it's not. I mean, I'm there most nights till 6 or 6:30, and I'd be there till 8 o'clock every night if we did a scan on every patient. The reason being that we're obligated when we take these things not to just kind of look at them quickly and say, oh yeah, this or that. We're obligated to look at the whole volume in all three dimensions, and it takes time to do that. It takes me about 10 or 15 minutes with each one to look at the whole volume. So that's one reason that we don't. We take them on the patients that we think we're likely to get valuable information. So we take them on virtually every retreatment because we want to know if there's any untreated canal space. We do it on all of our surgeries, and we do it on any case where we just can't seem to see things clearly on the PA, or we have some question about how many canals there are, or something just doesn't look right. We probably miss some things because we don't do it on every patient, but it's just not practical for us to do it on every patient.
What CBCT would you recommend if someone wanted to improve their molar endo? Is there any name brands any better for endo as opposed to the other spectrum like ortho?
Yeah, I mean, you want a small field that just takes images of a few teeth. For one thing, it makes it much easier to review the whole volume, and you're less likely to miss something else that's on there. Also, they have very low radiation. The small volume ones give off expose the patient to an amount of radiation that's approximately comparable to about 3 or 4 PAs. It's not very much. The particular machine that we use is from Carestream. I have a lot of friends that use the Merida machine, which is also a very good machine. Those are the two that most endodontists have. But there's lots of others on the market that are probably just as good.
Right, I hear Carestream's very, very, very popular. That's the one I got. When you see a general dentist do a misdiagnosis on a root canal, what do you think? What do they usually? What does the misdiagnosis usually come from?
Well, we see all different kinds. That's one thing that I think most dentists don't come out of dental school with a very good understanding of diagnosis, and I'm sure I was the same. We see things missed, obvious teeth that are obviously cracked, canals that have been missed. Sometimes, 95% of the time it's easy to make the diagnosis, but 5% of the time they're very difficult. And a lot of it is just they don't get exposed. We deal with it all day long as endodontists. Most general dentists only really have to make a difficult diagnosis once a week or a couple times a month or something. So part of it is the initial training.
I want to paint you a scenario that I hear when you're watching a football game in a bar and there's some young dental students in the deal. They say one of the things they hate the most about molar endo is when it's in the lower right, but you can't for sure tell which tooth it is. What would you tell that young dentist to do? they're not sure. Is that the second molar, the first molar, or second bicuspid? They all seem sensitive. They all seem to hurt, and they're trying to zero in on the exact tooth.
I mean, those are, I would say in anything, when in doubt, I would say refer them to their endodontist because they're probably going to be able to make the diagnosis. But I mean, we get these cases in where we can't make it easily initially either. And in most cases, we just wait. Usually with time, it becomes more clear. Now, if the patient's really in severe pain and we have to do something, this is going to sound funny, but all things being equal, when in doubt, treat the second molar.
When in doubt, it's usually second molar. And speaking of pain, here's another painful soul-searching question a lot of dentists go through. A lot of dentists, when they do a root canal, they were in pain. They want to get them out of pain, and they want to give them hydrocodone. And then there's a lot of dentists on Dental Town that says, you know, dentists and physicians are the one causing all these opiate addictions. And some dentists, I mean, there are a lot of dentists who just won't ever prescribe it. What should a dentist be? How do you personally, because you're in a conservative state of Texas, I don't know if it gets any more conservative than San Antonio, Texas. Do you prescribe opiates judiciously, or do you like, no, these are bad and go ibuprofen? What are your thoughts on opiates and opiate addiction?
We hardly ever prescribe them. When I say hardly ever, it's maybe once a month or something like that, and it's usually because the patient specifically wants that. The vast majority of the cases, well, it's kind of a complicated question, actually. So initially, when you see the patient, number one, you've absolutely got to get them completely numb to do the treatment. So patients that come in a lot of pain, they're more likely to have pain after the numbness wears off. So we'll give them a block with Marcaine at the end of the procedure to try to keep them numb for 4 or 5 hours. And that's really the critical period where they're going to tend to have a lot of pain. That gives them a chance to settle down, a chance to settle down. Now that's for a block on the mandibular arch. If it's severe pain in the upper arch, you know, we can't keep them numb that long. Marcaine only works about the same as lidocaine or any of the others. So, you know, an hour or maybe 2 hours max for most patients. So then we'll give them an injection of keto-lorac, which is non-steroidal anti-inflammatory, which provides really rock-solid analgesia for about 5 hours or so. It gives the tooth a chance to settle down.
And you inject that at the tooth?
Yeah, you know,
really?
They have to be numb because it's painful otherwise. And yeah, we just injected in the vestibule where we were working at the end of the procedure.
So it's like a liquid ibuprofen?
Yeah, it's stronger though. It's stronger than ibuprofen. And we just keep some in the office. We keep some ampules of it. And we don't have to do that very often. But again, probably once a month or something like that, we'll give them an injection of that. And it just gets them through that first 5 hours or so where they tend to have or people who had a lot of pain when they came in are more likely to have a lot of pain after the numbness wears off. And then after that, we can usually manage it either just with ibuprofen or with a combination of ibuprofen and Tylenol. That's usually all they have to take. Just alternate those every 3 hours. And if you look at the studies of analgesics, that combination is actually just as effective as the narcotics.
Same question. We hear the same guilt about antibiotic resistance. There are dentists, I personally know dentists who every single root canal they've ever done, they always give a prescription of Pen-VK or amoxicillin. And then there's other dentists that they will not do that unless there's some type of swelling.
Okay, so first of all, the literature shows that, and this has been pretty well documented, that giving antibiotics ahead of time doesn't make any difference as far as postoperative pain, postoperative swelling, those sorts of things. It doesn't make any difference. So the times that we give antibiotics, there's really only 2 times. One is patients that need to be pre-medicated for heart issues or that sort of thing, and patients who have systemic signs of infection. So swelling, big swelling, fever, and the other systemic signs of things. Those are really the only 2 times we give it.
Okay, I'm going to keep asking you these controversial questions. A general dentist is looking at this patient. It has a root canal. It's failed. and they're thinking, do I send this to the endodontist for a retreat or to the oral surgeon for an extraction implant? What are you thinking on these close calls between the retreat or treat with forceps?
Okay, so number one is what's the structural integrity of the tooth? What's the restorative prognosis for the tooth? If it's not so great, probably they're better off having the tooth extracted and having an implant or a bridge put in. The reason being that the retreatment process, if it's kind of a compromised tooth to start out with, the retreatment process is going to compromise it more. It's going to weaken the tooth more. That's just a fact. So that's probably the biggest factor. Another important factor is there, so if, let's say it's a structurally pretty strong tooth, is there untreated canal space? The retreatments that are most likely to be successful are the ones where there is an untreated MB2, where there's obvious untreated canal space. Another big factor for me, because a lot of the doctors refer them to me and I cut the crowns off and I'm the one that makes the determination of restorability. A really big factor for me is who's going to be doing the restorative after I'm done with them, who's going to be doing the crowns and so forth. If it's somebody that's really skilled, then I'll push the envelope more to more compromised teeth. If it's somebody that's not very skilled at restorative, probably the patient is better off with an implant or a bridge.
And do you think you will ever be, when you're doing the diagnosis and you cut off the crown and you decide that this needs to be extracted, do you see yourself in the future extracting it and place the implant single visit? I mean, some endodontists are doing this. Do you think that's a growing trend, or?
Yeah, it's definitely a growing trend. I have quite a few friends that do. And I think especially among the younger endodontists, they're doing it more and more. I mean, it's a nice service for the patient. The patients don't want to be referred here and there. And again, as long as the endodontist knows what they're doing and does a good job, the restorative dentists generally don't care one way or the other. You know, about 10 years ago or so, I was thinking, as implants became mainstream, I was thinking that we were probably going to get less busy, and that I took some courses on implants. My partner and I took some courses on implants, thinking at some point we were probably going to start doing them as things slowed down. But things actually never slowed down. If anything, they've gotten busier, and so we never made that move. But if I was a young endodontist, I would definitely get trained in doing implants, I think. I did some actually when I was a general dentist years ago, back when we didn't really know what we were doing, back in the 90s. Interestingly, during that time, about 10 years ago, I went around and talked to some of my restorative dentists, telling them we were thinking about starting to do implants. And I went and talked to some of the oral surgeons and periodontists that we dealt with. So the general dentists, they generally said, that's fine, as long as you do a good job. I don't care who places the implants for me. And the oral surgeons and the periodontists said, that's great if you want to do them. We don't want to do the single units anyway. Nobody had a problem with it.
That's true. They do a lot of big cases in a single unit. It's like an oral surgeon wants to pull 4 wisdom teeth, not 1 extraction. Gosh, so you could order that book, your second book, a CBCT Primer for Endodontics, or is that not published yet?
No, it's not. We're trying to get it finished by the end of the year, actually. I have actually a fairly small part in that. John Cotomy, an endodontist in Colorado, who I think goes on Dental Town quite a bit.
Absolutely.
He's the primary author. He's doing probably 80 or 90%, probably 80% of the work on it. And then Gary Carr has contributed to it, and then I've contributed a little bit. I actually told him he didn't have to put me on the cover since I didn't contribute that much.
How do you spell Cotomy, John Cotomy?
It's Khademi.
Khademi.
EMI.
And where is he in Colorado?
He practices in Durango, just this little town. He's another amazing guy, one of the best endodontists in the world. He practices in this town of, 5,000 or something.
Yeah, that's only about 4 hours from my house. I'm in Phoenix. That's near Four Corners. That's the only place in the United States where 4 states touch. Exactly. I love going up there. That's the most beautiful part of the country. I often say this to patients, and I only got you for 1 minute left. I say this to patients all the time, and sometimes I wonder, I hope I'm saying it right, but most people who study our human race, say that basically it's about 50,000 years old, and that from 50,000 years ago to 4,000 years ago, the average human only lived about 17 years. From 4,000 to 2,000 years ago, it went to 36, and now it's up to 74 for the planet. So a lot of times, like a 50-year-old lady will be sad. She'll say, well, why did my tooth die? And I say, well, your tooth probably was only designed to go about 17 years. And if you live long enough, I mean, I'm sure if you live to be 100 or 200 or 300 years old, they're all going to die. It's just the tooth dying because we lived so much longer than the design elements of the tooth. I mean, so for 50,000 years, it only was designed to go 17 years. Do you think just being 50 years old and living in this aging population that they just outlive their design life expectancy?
Yeah, there's definitely some of that. I mean, there's definitely some of that, just wear and tear, and bruxism is a big issue, and teeth cracking, and that sort of thing. It's interesting though, our average patient that we see is probably 65 or 70, something like that. I mean, we see a lot of old patients. And I guess kind of getting back to this implant endo thing, that reminds me of another little story. In this old patient population that we see them up into their 90s. I don't know if you've seen anybody in their hundreds, but that's part of that decision process too. Let's say that they're 70 or 72 and we're trying to decide whether to do endo or do an implant. As they get older, they have more and more caries because their mouth dries and they take more drugs and all of that. And if they're having a caries problem, we'll push them in the implant direction. Because implants don't get decay, of course. And the other thing is that if they're going to have a surgery, and we're worried that in 10 years we do endo in 10 years, there's going to be caries and they're going to lose this tooth, they're much better suited to deal with surgery and that sort of thing when they're 72 than they're going to be when they're 82. So that's another big factor in our old population when we're trying to make that decision on implants versus endo.
Yeah, I'm in Phoenix, which is a lot of retirements, and I tell you, the root surface decay is just it's one of the most I feel more helpless treating root surface decay. I mean, I can't tell you how many times you treat it in 1 year. You're back to square one. That is a vicious decay process.
I see some of these patients that some of the old prosthodontists in town treated, 30 years ago, did beautiful gold work and pin facings, and just beautiful work, really nicer than we see for the most part being done today. And anyway, these old people, they've got caries everywhere. It's all failing now. It worked great for 30 years, but they have caries everywhere. And gosh, what do you do? These patients are 75 or 85. It's really a difficult problem.
Yeah, and it's also one of to you younger dentists listening, probably my first diagnostic mistake trend that I did for the first 5 or 10 years that was so wrong. A lot of times those older people, older men, I was trying to patch things up because I thought, well, this guy's not going to live 5 more years anyway. And God, 25 years later, they're still alive. And I call it the Keith Richards syndrome. I mean, Keith Richards of the Rolling Stones, just people who, were on so much drugs and a wild lifestyle that they should have died decades ago and they're still alive. I can't tell you how you have to diagnose more aggressively because these people just stay alive forever.
What I've found is that, and I had earlier in my career, I dealt with some patients who had radiation, who had big caries rate, even younger patients. The only thing that stops rampant caries are fluoride trays. And I tell the patients, you have to have fluoride trays. You need to use them twice a day, every day, religiously for the rest of your life. That's the only thing that's going to stop this for you.
Yeah, but too often when you tell someone to use it religiously, they just use it on Christmas and Easter. Well, hey, Rick, I know you're a busy man, and I'm so honored that you spent an hour with me today. Thank you so much for all that you've done for dentistry, for endodontics. I'd give anything to have a course from you on Dental Town, as many courses, short, long as you want. And I'm really interested in these fiber posts. I think you could really help lead them away from metal post to fiber post. But again, thank you so much for spending the day with me.
Thanks, Howard. It was fun. Listen, I have the information about doing the courses. If you want to send me the information on writing an article, I'll do that.
Yeah, the editor is Howard Goldstein's the director of the website community and the online city, but the editor of the magazine is Tom Giacobbe, and
Okay.
since like 2000, so he's been doing it for 16 years. He's a great guy. So everyone's probably wondering, are you a big Spurs fan, San Antonio Spurs basketball fan?
Absolutely. Absolutely. Yeah, they're just, I've treated a bunch of them actually, and they're just great guys. They just get such great human beings besides being great athletes.
I think the funniest thing about basketball and the Spurs and the Suns is the basketball people, they say, well, we're a non-contact sport. I've never treated a knocked out tooth from a football player. It's always an elbow at a basketball. And I always say, oh, I thought that was a non-contact sport.
Not anymore, not with these guys.
Okay, well, thanks for spending an hour with me. I really, really appreciate it. Bye-bye.